Hello and welcome to the second video in a webinar series around postural management. My name's Richard Harvey and I'm the Clinical Training Manager for Jiraffe and for Jenks. So if we first of all just take a look at the webinar series itself and just an overview of what we're going to include in the whole series. The first video, that was around the introduction of postural management. So if you have not had any experience with postural management before, take a look at that first video. And really this whole series is aimed towards anybody that's involved in the care of somebody with complex disabilities. So if you're a therapist or a healthcare professional, family member or a carer, there'll be something within this series that will be for you. We're also going to take a look at the impacts or the things that impact our posture and the risks associated with that. So we touched upon that in the first video, but we'll go into a little bit further detail later on in the series. We're going to take a look at how to build a stable posture in seating, in standing and in lying. We'll look at the fundamentals of assessing for posture, and then at the end of the series we're going to take a look at different types of equipment and basically how to choose the right piece of equipment for the user's needs. So just a little bit about me to begin with. I've had around 8 years experience working within the NHS, and that's in a variety of different roles and settings. That experience coupled with my experience at Jenks and Jiraffe, I've had quite a lot of experience assessing people's postural needs, especially those with complex disabilities. And from that, I've been involved in recommending equipment provisions in seating, standing, sleeping, bathroom and mobility. I've also gained a postgraduate certificate in postural management for people with complex disabilities, and I undertook that up at the Oxford Centre of Enablement. Today's presentation is on anatomy and biomechanics. We're going to take a look at how this relates in postural management and some of the things that we need to consider when we're positioning people. We'll have a look at the skeletal system and different segments of the body. We'll also take a look into how different positions of those segments can relate to the rest of the body as well. We'll have a look at muscles and our soft tissues, especially around plasticity and how adopting poor positions can affect the plasticity of our muscles. And finally, we'll have a look into range of motion and why it's so important that we have those ranges of our joints in order to adopt different positions. So first of all, if we have a look at the skeleton itself. So whenever we think of postural management and positioning someone over a 24-hour period, the first thing that we need to consider is the pelvis. So the pelvis is really the cornerstone of everything we think of postural management wise. And that's because it will affect everything that happens above it and everything that happens below it. So when we think of positioning our lower limbs, for example, we really need to start at the pelvis and work our way down. So if we take a look at this next slide, we've got section A here, which is a neutral pelvis. You can see the red line there that runs in front of the pelvis from the anterior superior iliac spine, which is the kind of the bony point at the top of the pelvis. And then you can see at the bottom of the pelvis here that the pubic bone, it's all nicely aligned in a neutral position. If we take a look above the pelvis there, you can see that the spine is kind of nicely aligned over the pelvis, and the lower limbs also are just nicely aligned there. So if we take a look now at the section B, and we've got an anteriorly tilted pelvis. This basically means that the pelvis is falling forward. So you can kind of see on this image that the anterior superior iliac spine, or the ASIS, is in front of the pubic bone. And now if we look above the pelvis, we can see what's happened to the lumbar region of the spine. We've actually started to begin to have a hyperlordosis there. Now if we move on to the next section here, section C, we've got a posteriorly tilted pelvis. So that's really sometimes what we call sacral sitting, so where we're sat on the sacrum and those kind of those fixed bones at the back of the pelvis. So the anterior superior iliac spine is kind of behind the pubic bone there, and we can see that the lumbar spine above the pelvis has actually become a lot more flat now. So if we keep that in mind for the next slide, what's happened to kind of the pelvis and how that relates to the spine. Now that we've got an understanding of what an anterior or posteriorly tilted pelvis looks like, let's take a look now at how that may affect us in a seated position. So first of all, we have a neutral pelvis here that's nicely aligned. We've got the sacrum bones nicely supported at the back of the chair. And as you can see, the spine is nicely stacked above the pelvis. The legs here, they're at a 90 degree angle. So that's at the hips, the knees and the ankles. And that's the gold standard that we strive for in seating. Now, if we take a look at the anteriorly tilted pelvis, so we can see that pelvis is coming forward. We can see what's happening to the lower part of the spine here in the lumbar region, how that's had an extended curve there. We can see that the lady's been pushed forward as well, so that her back is not being supported at all by the back of the chair. And we're probably over that 90 degree angle. It's more of an acute angle at the hips there, so it's not really ideal for a seated position. We'll take a look in another webinar at what the implications could be and the secondary complications of an anterior tilted pelvis. If we move on now though to the posterior tilted pelvis, and that's something that we do see quite often, is that slump position. So the pelvis is in a backward leaning position. We often call this kind of sacrally sat. And you can see here that the pelvis is in that tilted position. The lower part of the spine, the lumbar region, is flattened, which has increased the curve of the spine going up into the neck. So there's a lot of issues around that, which we discussed in the first presentation, around communication, around swallow, and all the kind of pressure that's going through the mid-thoracic part of the spine there, and also the sacral bones. So we've also opened up that hip joint as well. So we're no longer at a 90 degree position of the hips as well. So if we're not careful and we maintain that position over a long period of time, there's a few issues that we'd have around kind of fixing those degree of angles in the range of motion of the hip. So if we now take a look at what a pelvic obliquity might look like, on the far end of this slide you can see how one of the side of the pelvis is higher than the other. However, on the next slide here we can see it depicted in a slightly easier way. So this is the back of the pelvis, so the posterior superior iliac spine, and you can see that one is higher than the other. Now this can be either a fixed obliquity or a flexible obliquity, and if it's either, we need to do very different things. So if it is a flexible obliquity, we look to correct that, whereas if it is a fixed position, therefore it can't come back into neutral anymore because it has been fixed over time, then we need to accommodate that position so that it doesn't get any worse. Now, if you just take a look at the bottom of the pelvis here, we've got the two sitting bones, the ischial tuberosities. On the right hand side, the lower part of that pelvis, we've got all of the weight. If this was in a seated position, all of the person's weight of the top half of their body would be going through that one sitting bone. So obviously there's loads of issues around pressure, which we'll go into a bit further in the secondary complications video that's to come. But really this is something to look for, especially in a seated position, that a lot of the person's weight might be going through one of those sitting bones. Now this picture doesn't depict what's happening to the spine here, but it's quite likely that there might be a possible scoliosis that might form from this, because the pelvis itself is tilted, therefore the spine itself is also likely to follow that curve. Now, another situation that can arise is a rotation of the pelvis. So that's where either the left or the right hand side of the pelvis is further forward than the other, and this can give the impression of a leg length discrepancy. So if you are having a look at somebody in a seated position and you notice that one leg is in front of the other, a reasonable thing to surmise is that there might be a rotation of the pelvis. So that's the first thing that you might need to check in that situation. If we're talking about leg length discrepancies themselves, very infrequently is actually an issue to do with the femoral bone itself. So there's a number of congenital disorders which can cause one femur to be longer than the others, but usually when we're thinking of postural management, it's either a rotation or an obliquity of the pelvis that causes that appearance of a leg length discrepancy. There's also things around hip subluxation and dislocations which may cause a leg length discrepancy, and we'll take a look at that in a second. But this is one of the things to be mindful of, because if you do have a rotated pelvis and you're looking to create a position with someone, whether this is in lying or seating or in standing, if that's a flexible rotation and we don't correct it, then that can become a fixed issue. Now, if we take a look at the legs, there's a lot of different things that can happen with our lower limbs because they're really flexible and we've got loads of joints in them. So the pictures in front of you are depicting internal and external rotation. So there's a few issues around internal and external rotation that we need to be aware of, especially if we think of hip development. So when we are all children, before the ages of around 6, all of our bones are very malleable, and our hip joint isn't actually formed yet. And it's the process of us being in an upright position and gravity bearing down through that joint that actually forms the acetabulum and head of femur socket joint. Now, for children that have got quite complex disabilities and aren't able to stand or adopt those positions, though that joint doesn't always form correctly, which leaves them at higher risk of subluxation and dislocation. Now, having an internally rotated leg as well, so if we think of children maybe with spastic cerebral palsy that have that tone, the chances of subluxation and dislocation is also quite high, and that's where the knees are basically rotating inwards towards themselves. And what happens to the head of femur is it starts to rotate out of its socket as well. So when we think of rotated positions, that's something to bear in mind. And if someone's adopting that position over a long period of time, then those issues can be of higher risk. Now, external rotation, you kind of see this probably more in maybe children with Down syndrome or lower tone. That's where the legs will fall out to the side, which isn't always a bad thing when we think of hip development, because that external rotation in the hip actually creates more internal rotation and fixes it into place a little bit better. However, any extreme of either is also something that we need to bear in mind and to recognise in postural management. So if we take a look at adduction, I like to think of this as adding the limbs together. That's how it reminds me of what adduction is opposed to abduction. So adduction is where the limbs are coming in towards the midline or crossing the midline position. So again, similar to what we were talking about around internal rotation, if the lower limbs are adducting and also internally rotating, that's further drawing the head of femur out of place in the hip socket as well. So the risks again of subluxation and dislocation are higher in children and adults that adduct and internally rotate. You've also got a picture in front of you with a young person in a standing position whilst adducting, and that really is an issue as well when we think of standing, because it's narrowed that base of support, so we don't have that wide base of support that we look for creating a stable posture, and because it's narrowed itself by coming in towards midline. Now, if we look at the opposite to adduction, which is abduction, the way that I think of that is abducting something, so taking it away, so drawing it away from midline. There's actually a number of benefits to standing in abduction, which again we'll cover in a later video, but again with the idea of forming that hip joint in younger children by abducting the legs and creating a little bit of external rotation, we're able to fit the head of femur into its socket a lot better. Now, again, children with hypermobility and low tone, they tend to abduct more than children with higher tone. So this is kind of an issue around things like W sitting, where we're adopting poor positions and we're stretching those soft tissues into positions that we don't particularly want to, because they're not conducive for kind of a standing position or adopting a comfortable seated position. So this slide here really depicts what we were talking about earlier around those issues around dislocation and subluxation. So the first image here is of a normal, normally developed head of femur and acetabulum. So you can see that that's nicely in place. The acetabulum, or the groove that's been formed in the pelvis, fits nicely with the head of femur, and everything is kind of in place. And then if we look at the next image, which is of a subluxation, so that's where the head of femur has started to come out of the acetabulum there. You can first of all notice that the groove itself, the acetabulum, isn't fully formed, and it's not as deep as we'd like that to be. You can also see that the white lines within the image depict the tendons and the ligaments around that joint, and how they're starting to become overstretched. And then we can see the low and the high dislocation, which is a partial or a full dislocation. You can see the effects again with those white lines, which are depicting the soft tissues and how they've been overstretched, and how that will actually adapt over time. So if that issue wasn't resolved, all of those tendons would be overstretched. And you can also see the acetabulum itself, and how that's not fully formed at all in comparison to the normal developed hip there. So that's just an image really to give you an idea of what happens if a hip joint isn't formed fully. Now if we take a look at the feet are really important when we think of seating and standing, and that's because they are what make contact with the floor. And we need as much surface area of the foot to be making contact with the floor as possible. So we look for a really flat foot, or what's called plantar. If the foot is pointing up towards the ceiling, so if the toes are kind of pointing up towards yourself, that's called dorsiflexion. If the foot is in a downward position, so the toes are pointing towards the floor, that's called plantarflexion. If we think of a plantar-flexed foot that's in a fixed position, and we want that person to be standing, it's going to be a little bit more difficult, because the only part of the foot that might be making contact with the floor would be the toes and the ball of the foot, which is obviously a lot smaller a surface area than the whole foot. So not only is that an issue around pressure and all the pressure that's going through the toes and the ball of the foot, but also it's a less stable posture, because we aren't making as much contact with the floor. Now the other image that we have on this slide is pronation and supination. So that's where the foot is rolling inward for pronation and outward for supination. And again, what that means is that we're making less contact with the floor, where it's just either the lateral border or the medial border of the foot that's actually making contact with the floor. Not only is again, that's a pressure issue, but the amount of strain that will be going through the ankle joint, if it's not in a neutral position, also increases. So that's something just to bear in mind when we're looking at the feet. Now if we move on to the spine, we already know that the pelvis can really affect the spine. So if it's tilted forward or backwards, if it's up on one side, that can really change what's happening to that lower part of the spine. So first of all, if we look at a lateral curve or a scoliosis, in front of you here we've got two examples of scoliosis, an S-curve. So that's where the lateral curve has started one way and it's tried to correct itself and started to move the other way. And in doing so, that's created a secondary curve. So if we think of the issues that can surround a scoliosis, the kind of the widening of a rib cage, or what we call a rib prominence or a rib flare, that can be very uncomfortable for someone. It can create a bony prominence. So if we want to get into a lying position, we've got another bony prominence to think about, and in terms of pressure and being a point of contact to the surface. Also, if we have got a lateral curve of the spine as well, it might also close off one side of the rib cage to make it more or less efficient for the lungs to function. So if we've got any respiratory issues, having a scoliosis can also affect that. And the other example of a scoliosis we've got here is a C-shaped scoliosis. So that's just with one curve of the spine. We can also see on the right hand side of the slide here that we've got another scoliosis here, and we can almost see that the spine itself is rotating because of that. So again, that's putting more pressure on each vertebrae by having that rotated position. And if that's adopted over a long period of time, all of those soft tissues that connect our vertebrae, so all the little ligaments, can shorten into position, and it's going to be harder for that to come into a nice neutral position. So moving on, we have got a slide here that depicts what a kyphosis and a lordosis is. So a kyphosis is the top section of the spine where it's curving forward, and this is often caused by, again, that posterior tilt of the pelvis, where the lower part of the spine is flattened out and it's increased in the kyphotic part of the spine, the top part of the spine, to create more of like a hunchback. So there's a lot of issues around a kyphosis that we spoke about before in the first video around communication. But really what's happening here and the issues we need to consider is the fact that the kyphosis is pushing the head forwards. So when gravity is bearing down on us, if the head is further away from the body, the moments of force that's going through the top of the spine there is greater. So that curve is actually it's more risk of developing a worse curve. So if that's a fixed kyphosis, we really need to be mindful to ensure that doesn't get worse and manage that. And if it's a flexible one, we really want to be pulling that thoracic region of the spine back so that we're in a nice aligned position. Now the other thing that this slide's depicting is a hyperlordosis. So that is where the lordotic part of the spine, the lower section of the spine, has become increased in its curve, and it's this is often again due to an anterior tilt of the pelvis, which you can kind of see that the lower part of the abdomen is also being condensed as well because of this. So if we think of any digestion issues that could possibly be caused by hyperlordosis, and it also puts, in a seated position, puts more pressure on the pelvis and also at the kind of arteries that sit around the pelvic bone as well. From these spinal issues, there are a number of things that can happen as well to the chest. So we've already mentioned around rib prominences and rib flares. So if over time a spine has kind of been brought out of position, parts of the rib cage can flare out and become quite prominent. So again, if we think of somebody that's wanting to lie on their side onto that curve, the curve itself and any rib prominences is going to be impacted first of all by the supporting surface. So that again could increase pressure, discomfort and pain. So again, as we're talking about the kind of the top section of the body and the spine, if we look at the shoulders and the different things that can happen to the shoulders, first of all, what's called retraction, or where the shoulders are brought right back. We see this a lot in children with high tone or spasticity, and their tone might be sitting a bit higher in their body. Now the issues around that is if our shoulders are too far retracted, it's much more difficult for our arms to be in midline. So we're not able to engage in our activities or in our therapy, and really we need to look to bring them forward into a neutral position so that we're able to achieve that midline position. Now the opposite to that is protraction, where the shoulders are rolling forward, and you can probably see when I'm doing that the rest of my spine is also coming forward into that more kyphotic position. So often those protracted shoulders can cause a bit of kyphosis, and just by bringing those shoulders back into alignment can also align the rest of the spine. And also if we just look at different neck and head positions, so an extended neck, or sometimes called a chin poke, where the head's coming forward and the neck's fully extended, this can obviously have a few issues around breathing and swallow that we need to be mindful of. And then the opposite of that, the flexion part, where it's more of a chin tuck, again issues around swallow and breathing, but also we've spoke again about that communication, where if our gaze is only towards the floor and we rely on eye-to-eye communication, then that just takes us away from the world. And then we've got different lateral flexion, so our head from side to side, and also rotation left to right. A lot of children with spasticity that have a lot of high tone in their upper regions of their body can be affected by that. And it's really managing that with the head into a nice aligned position so that we can engage in our activities, whether that's classroom based or at home, and also when we're thinking of feeding, and what is the best position, the most neutral position for that. So now that we've looked at the skeleton and the different parts of the body, we'll go on to talk about the secondary complications that can lead from the issues that we've discussed in the next video. But for now, if we move on to muscles and soft tissues, and we're going to take a look at plasticity and elasticity and why that's so important and something that we need to look out for. So if we take, for example, some of the forces that we were mentioning in the first video, so if we take the idea of a compressive force, so pushing something together, if we apply that force to an object, and once we've released that force, if the object is able to regain its original shape, that's what we call elasticity. Now, if we applied that force to an object, and the stress and the strain is too much, and once we've released that force, if the object is no longer able to regain its original shape, that's what we call plasticity. So if we think of that in terms of maybe a piece of blue tack, that if we pulled that apart, if we pull it quite gently apart, it's able to regain its original shape. But if we pull it a little bit too much, it will become a lot longer and it won't be able to regain its original shape. And this can lead to the object snapping, breaking, or becoming deformed. So if we think of that in terms of a muscle or soft tissue, we can think of maybe the Achilles tendon. So if we think of a sprinter or an athlete that's training and creates too much force when he or she's pushing off, and his or her Achilles tendon becomes overstretched so that it doesn't actually come back to its original shape and actually snaps, that's the Achilles tendon going into plasticity and then breaking. So this next slide here with the graph on just depicts that the idea of going through the range of elasticity into plasticity and then a fracture or breaking. So if we keep that in mind, but also think what happens to the muscular system. So what it does day to day, we move, our muscles move, we twist, we look around, we flex, we extend our muscles. So it's constantly being moved. We've spoke about trauma as well, so that a sports injury, for example, or an accident can change the muscular system itself and cause damage. So thermoregulation, so muscles or soft tissues getting warmer or cooler makes them contract or shrink down. But the thing that I really want to focus on today is immobility. So what happens if we're not able to move our muscles or soft tissues? For example, I had a friend very recently who fractured a bone in his hand. So for 3 weeks, he had to be in a cast where his hand was fixed in this position. So after those 3 weeks, when his cast was removed, his ability to flex his hand, to go into full extension of his hand, he actually was not able to do that. He was only able to go maybe to here at first, and then over time, through a bit of rehab, he was able to regain that full range of motion. So if we think of broken limbs like that and that not being able to be mobile, it's a really good example of how quickly soft tissues can adapt over time. Now, if it was myself that happened to, because I'm quite an able-bodied person, over time my body should be able to recover, and through some rehab, that'd be great. People with quite complex disabilities or people that aren't able to adjust their positions or are immobile, that you're not always able to regain that range of motion, and then over time that can become a fixed issue. So if we take a look at the negative things that can happen, so we've just spoke about muscles, tendons and ligaments becoming shorter or longer. So again, if we're fixed in that position like my friend was, over that 3-week period, those ligaments and tendons had shortened on the inside of his hand and lengthened on the outside of his hand. So doing the movement of being able to get himself into complete flexion, he wasn't able to do that because of the shortening of those soft tissues. And over time, like I mentioned, that can form contractures. So for people that aren't able to get that full range of motion, over time, if they're not able to get that, that will be fused into that position. And if we think of how that relates to, for example, a position in seating, if we're not able to gain those 90 degrees of our hips and knees and ankles, that's going to draw us into a really difficult situation where we're going to have to accommodate certain positions that aren't optimal. So the other thing to consider as well is muscle wastage or atrophy. So if we don't use a muscle, it actually doesn't take very long for that muscle to start wasting away. It only actually takes a few days for that atrophy to start to set in. So again, if I use my friend as an example that's been fixed in that position where he's not able to use his hand as much, the kind of the muscles in his forearm started to become weaker and they started to atrophy. So in comparison to his other arm, it become smaller. A person that is non-mobile, that's obviously going to happen a lot quicker, and it can also lead to kind of permanent and irreversible problems as well. So finally, we're going to take a look at range of motion. So range of motion is basically how mobile a joint is and how that limb moves in its joint, and that's measured in degrees. So we've already spoken about adopting a 90-90 position in seating. So that basically means 90 degrees at the hips, knees and the feet. And we've kind of covered why that is beneficial and why we think of that as a gold standard of seating. It's not to say that if you can't reach those angles of degrees that you can't be in a seated position. It just means that we need to think a little bit further about what we're doing and how we're accommodating that position. Similar in standing, it's more beneficial to stand completely upright in a fully extended position so that our weight is distributed evenly through our hips and knees and our feet. Again, it's not to say that if you have some flexion in your hips and knees that you can't stand or that you shouldn't stand. It's again just having that awareness of pressure and the amount of force that's going through a slightly flexed lower limb. And again, if we think of lying and having ranges of motion, I like the statement lying well to sit well. So basically that means that you can adopt a really good seating position in the day and maybe standing for an hour or so in a standing frame. But if we're not really looking at what we're doing at night time, we could be undoing all of that good work in the day. So if we're adopting a really poor contracted position, maybe in a lying position, over time that can really affect the range of motion in our joints and makes it less efficient for us to sit and stand. So really lying well to sit well is something that I'd like you all to get into your brains as well. Also, it's important to retain that muscle length and create different postures. So again, especially in that lying position and a fully extended standing position, it's retaining those muscle and soft tissue lengths to be able to do that. And it's also really important to think of abduction and adduction that we've already spoken about around those issues with internal and external rotation as well. So if we're in a lying position and in a kind of a windswept position, and over time if that starts to fix, it's going to be more difficult for us to be in a seated position if our legs are swinging over to one side, because that creates less stability. It can create more issues around the hips if we're kind of externally rotating at the hip, then that can create more problems. So if we just summarise and encapsulate what we've learned today in a few kind of bullet points of what we'd like you to take away today. First of all, the pelvis, it's the cornerstone of everything postural management wise, and that is because it affects everything that happens above and everything that happens below. So if we get that right first, we have a better chance of getting everything else right as well. And we've already seen how that can affect different parts of the body as well. So we've also looked into the different body segments and how they relate to one another. So for example, we've looked at the pelvis and how that affects the spine and the lower limbs. We've also spoke about the asymmetries that can form, and that has a bit of a domino effect. And we're going to look into the secondary complications in the next video. We've spoke about muscles and soft tissues and plasticity. So if we go past that point of no return, especially for people with complex neurological conditions, the evidence shows that they're not actually able to regain that plasticity back into kind of an elastic state. We looked at immobility and how that can affect our soft tissue, so the shortening and lengthening of soft tissues and how that can form over time and form contractures. And then we looked briefly at range of motion and why that's so important for our joints to be able to gain those different stable and safe positions, such as a seated and standing position. So thank you very much for watching this last video. The next one we've already mentioned is around secondary complications. So we're going to take a look at the issues that we spoke about today and what the knock-on effects can be in the next video. So again, thank you for watching and listening, and I look forward to doing the next video.